I have only two specimens because originally there were a lot, but they were actually operated cases, and after operation we cannot see the TAPVD. So this is only two cases with unoperated TAPVR. Okay. So original diagnosis is right atrial isomerism, AVSD, TAPVR, and retrobronchial vertical vein, pulmonary stenosis, and ventricular arterial discordance. So definitely this is the case of TAPVD associated with right atrial isomerism. So you see the heart, large aorta is here, and pulmonary artery, you could find, no, not here, yeah. This is pulmonary artery behind the aorta. And if you see the rear aspect of the heart, then you see the common pulmonary venous channel, and this is vertical vein, and the course of vertical vein is behind the right main bronchus here, and is draining to the right side SVC here. So this is right side SVC, and is draining to the junction between the SVC and the right atrium here. So usually in patients with isolated TAPVD, isolated supracardiac TAPVD, the vertical vein is usually in front of the left pulmonary artery. But in this case, the course of the vertical vein is behind the bronchus. And long time ago, Dr. Tae-Jin published a paper regarding the course of the vertical vein in patients with supracardiac TAPVD associated with right atrial isomerism. Would you elaborate on that a little bit?
So in sinusitis, usually the vertical vein is in front of the pulmonary artery and in front of the bronchus. But in right isomerism, not always, frequently, actually vertical vein is behind the pulmonary artery, actually behind the bronchus, and is taking a long convoluted course to connect to the superior vena cava. That is what Dr. Yun said. We observed that in the clinical context and the specimen, not always, but frequently.
How do you deal with this problem surgically?
Well, the TAPVD associated with right atrial isomerism is characterized by the small size of the component pulmonary vein, and also it is buried in the posterior pericardium. In isolated TAPVD, actually you can see the component pulmonary vein easily through the transparent posterior pericardium. But in patients with right atrial isomerism, the common pulmonary venous channel is buried deep. So usually the surgical repair is suturous repair, not directly correct the common channel to the atrium because of the small size of the conference and also the deep buried location of the common pulmonary venous channel.
Thank you.
So this is the case of supracardiac TAPVD associated with right atrial isomerism. Actually, I was interested in that, and I a long time ago, I looked at our cases and I found that at the time we had 9 patients with supracardiac TAPVD in right atrial aneurysm. 5 had vertical vein behind the bronchus. 4 had a vertical vein in between the left pulmonary artery and the left bronchus. It should have been quite obstructive there. And 1 is in front of the left pulmonary artery. Yeah, this is another case of TAPVD. Here, it's difficult to see, but yeah. This is common channel, and it's draining down to the portal vein here. Presumably, this case is also TAPVD associated with right atrial isomerism. When the common channel is draining to the portal vein, the diaphragmatic exit point is usually esophageal hiatus. And in that point, the obstruction may occur. Usually, in patients with right atrial isomerism, the esophageal hiatus is big enough. So some patients is associated with hiatal hernia. So usually not obstructive in most of the patients, but after you start feeding, distension of the stomach and esophagus, it can be obstructive there. So you got to be very careful. I keep the patient on NPO before the surgical correction of the TAPVD. And also, it's draining to the portal vein and should be drained to the systemic venous return. So the liver parenchyma itself is obstructive as well. So 2 points of obstruction, potential obstruction. One is esophageal hiatus level, and another one is liver parenchyma. And the morphology of the common channel looks good, but in some patients, the morphology of the common channel looks like a reverse Christmas tree morphology that is draining like this down to the portal vein. So it's very difficult to connect the common channel directly to the atrium. So in the case, we do sutureless repair for the pulmonary vein.
Yoon, when you do the TAPV repair, how should we treat vertical vein? Some cases, for me, some patients are left open, don't touch, don't ligate, or how about your infracardiac, supracardiac?
Usually I divide. Usually I divide the vertical vein down to the portal vein, because then you can get a better configuration of the common channel.
For me, infracardiac type, TAPVC, when I do the sutures technique, so that means the right side, left side suture technique, and if we ligate or division vertical vein, that we should dissect there, right? So in that case, it's very difficult to do the sutures.
Yeah, it's tricky part of the surgery. You got to be very careful not to open up the dissect too much, because sutureless repair necessitates the integrity of the posterior pericardium. So sometimes we can try to internally obliterate the vertical vein from the common channel side, but usually I divide the vertical vein down to the portal vein.
Actually, I did left open vertical vein. So fate of the patent vertical vein may be there is no significant shunt.
Yeah, some are saying that. Anyway, most of the patients are Fontan candidates, so the connection of the common channel, remnant channel to the portal vein doesn't make any problem. You're right. I just do divide the vertical vein downward vertical vein just because I want to make the operation easier. Okay, I'm done.
Thank you.